Okay, good afternoon, everyone. My name's Catherine Ellis. I'm the Deputy Lead of the Wellbeing and Ageing team at the University of Melbourne. It's my absolute pleasure to be here today to chair our Seminars in Ageing program. So, welcome everybody. I know a few will be jumping in as I'm doing this little introduction, but I'll honour everyone's time and get us started on time because we've got a fabulous speaker today. Before I do start, though, I'd like to acknowledge the traditional owners on the lands on which we're all meeting today and pay my respects to elders past, present, and emerging, as well as any Indigenous people joining us here today. A little bit of housekeeping before we start. We have the chat function turned off on Teams. You won't be able to add anything in the chat, but we do want to hear from you. So we have the Q&A function there. If you've got any questions for our speaker, please enter them at any time. They'll be visible to us when we finish the presentation. And so I'm sure our speaker will be willing to address those questions and we'll be able to have a good conversation. Just a reminder that this is being recorded. So if you do unmute yourself and put yourself on video, that will be part of the recording today that will be circulated by NARI over the next couple of weeks. Okay, so let's get into it. I am so delighted today to introduce my friend and colleague, Dr. Terence Chong. Terry is a senior lecturer in a joint position between the University of Melbourne and St Vincent's, where he is also a consultant psychiatrist in old age mental health. He's recently submitted his PhD, and I hear whispers that is very close to being passed. His research interests include cognitive health and dementia prevention, intervention and care, anxiety, physical activity, and the use of technology to facilitate interventions. He also holds appointments as I said, as a consultant psychiatrist at St Vincent's Hospital, but also Epworth Healthcare and Medical and Mind Weight Loss. He's on the board of directors of the International Psychogeriatrics Association and is currently their treasurer. And today, Terry's going to be talking to us about exercising your worries away, giving us an update on a presentation that was really well received in this Seminar in Ageing program a few years ago. So I'll hand over to you. Thank you, Terry.
Great. Thank you so much, Catherine, for that very kind introduction, and welcome everyone to the talk. It's always a bit harder to know how fast or slow to go in a webinar because I can't see you in the audience, but I'll do my best to cover quite a bit of territory during this talk, but also not go too fast or too slow. So that'll be my challenge today. So today's talk is about exercising your worries away. I did a similar talk a few years back, and so I will cover a bit of what was said a few years back because I know that not everyone would have necessarily been at that talk, and then an update as to where we're up to now. And there's quite a bit to cover because I'm talking about a number of years of research. So, just by way of introduction, Catherine's already described where I work, but one of my jobs at the University of Melbourne, we used to be called the Academic Unit for Psychiatry of Old Age. We don't actually have a new sign yet for with our new name, which is the Wellbeing in Ageing team. And so that's our new name. And physically, I spend most of my week at St George's Hospital, which is a campus of St Vincent's that's out in Kew. So there's a photo there of it. The photo is actually from the movie, from one of the Mad Max movies. I think it was the first one, and the hospital was a filming location for that movie, which is really interesting because surprisingly, or not surprisingly, things haven't changed all that much in terms of the buildings there at the front since the film was made. So if I was in a room with you, I'd ask you all to put your hands up. I don't think we have a poll function, so I'll just get you to imagine your answers inside your own minds. So there are just two poll questions to, I guess, keep you thinking as we go along. So in Australian adults, which of the following type of disorders has the highest 12-month prevalence? So affective disorders, think if you'll vote for that. Anxiety disorders, think if you'll vote for that one. And substance use disorders. You'll probably realise that it's a bit of a loaded question given what the talk's on. And yes, if you picked anxiety disorders, you would be correct according to the most recent National Survey of Mental Health and Wellbeing. So what is anxiety? So if we go to the Oxford English Dictionary, so not a medical dictionary, it talks about a feeling of worry, nervousness, or unease about something with an uncertain outcome. And it comes from the Latin to choke. So you can see that's actually a pretty accurate description of what we understand of the term in a clinical sense as well. And the derivation of the word to choke already gives you that sense of the physical manifestations that can come from anxiety. So is anxiety a good or bad thing? And when I ask that question, I usually get a range of answers, but most people would say that it can be good or bad, which is exactly what we would think. I won't spend a lot of time on this, but essentially our brain directs the staying alive machine. So if we're in danger, we have that really powerful fight, flight, sympathetic nervous system response. And also, we have a body that makes sure we don't ignore this. And it's pretty hard to ignore when we get this. And so from an evolutionary perspective, we're the descendants of people who had good staying alive machines. So people who learnt very quickly that leaves rustling in the forest meant that was a lion coming, and had a response that they couldn't ignore and were able to either fight or flight in that setting. If people weren't good at making that connection, they were less likely to survive. And if people didn't have good flight responses, they were also less likely to survive and then have future generations that we're descendant from. Also, as those of us who have looked after people with anxiety or have experienced anxiety ourselves, it is very hard to unlearn anxiety as well. It takes quite a bit of work. And so again, part of this is a survival thing. I mean, if we forget very quickly that leaves rustling equals a lion, then we're less likely to survive again. I guess the problem for us is that if I'm here in Kew, if we're walking up Cotham Road or Burke Road where we are, it's unlikely we'll encounter a lion. And if we're just going to Coles down the road, it's also unlikely that we'd encounter a lion there. So we've got these systems which are really well geared up to survival, but they're getting triggered in environments which really aren't quite so dangerous. And so it becomes a very unpleasant thing that we're experiencing instead. So we lead on to the Yerkes-Dodson curve, which is the second part of the answer. As you can see here, there's a kind of sweet spot of anxiety where we function at our best. Too much and our function drops off, and too little, we don't function very well. And I usually use a bit of a footy analogy here, and apologies, I'm a Collingwood supporter. So Craig McRae is the coach, and his job is to get the players performing in that optional, I don't know if that's a Freudian slip, but in that optimal zone there. So if they're not revved up enough, they're just second to the ball, they're not quite focused, they just don't play as well. If they're too revved up, they start making silly decisions, giving away 50-metre penalties for not good reason and so on. So we're aiming for that optimal zone. So before we launch completely into the researchy bit, just for us to step back and reflect a little bit, especially for clinicians, if we see a lot of people experiencing anxiety, it can sometimes lead to us becoming immune to these stories, which we don't want to be. So I think we've all experienced anxiety to some extent, whether it's giving a talk like I'm doing now or standing, on a very high level for those who dislike heights, or walking along the pavement and a truck goes past quite fast and without a huge gap between us. So we do experience this fight-flight response and anxiety, and if that can be magnified by several degrees of magnitude, and kind of a lot of the day, all day, every day, then we can try to then get an understanding of what our patients might be experiencing. And we know that anxiety is an exaggeration of the normal behaviors and cognitions that we all experience, but that's become a whole lot more intense and causing us a lot more distress and impacting on our function. So the second poll question, again, I'll get you to vote in your minds. So which of the following celebrities have spoken publicly about their anxiety? So voting for Hugh Grant, Ariana Grande, Ryan Reynolds, Emma Stone, and all of the above. So the very well-regarded peer-reviewed journal, The Hollywood Reporter, tells me that the answer is all of the above. So if you said that, you got that correct. And I think, to me, that's a really encouraging process, that people who are kind of well-known, or that celebrities have publicly spoken about their experiences of anxiety, and that I think is helping us to reduce stigma around anxiety and around mental health in general, which is a really important thing for people to know, that it is something that's common, that many of us experience, and that there is help out there, and it's not necessarily something that should be attached to stigma or shame. I'll briefly cover what the DSM says about anxiety disorders, or at least the types of anxiety disorders, but we also have to be mindful of not over pathologizing or over diagnosing normal human experiences. Otherwise, cartoons like this come true. So in terms of anxiety disorders, the DSM talks about specific phobias, which are specific fears, for example, spiders, heights, etc. There's social anxiety, which is a specific, which has that specific trigger of social situations. There are panic attacks as part of panic disorder, and agoraphobia, which is the avoidance of places where we can't escape if we do have panic. Generalized anxiety disorder, which is anxiety around a number of everyday worries, concerns, and as with all the DSM chapters, they also have anxiety or other conditions that could be caused by a medical condition, such as a condition that causes shortness of breath, or an overactive thyroid, for example, or induced by substances, whether that's prescribed, like prednisolone, for example, or substances that are non-prescribed. Again, very briefly, just more to show you that they exist. The College of Psychiatrists has clinical practice guidelines, and that involves, as you see here, assessment, initial management, assessing comorbid conditions, substance use, risk, stresses and triggers, and supports. The first line is usually providing advice on lifestyle, and we're going to focus a bit on exercise and physical activity going forward. And you can see it's in there in the top box. We address substance use and provide education. And then depending on what's needed, the most evidence-based treatments available are cognitive behavioral therapy, and also medications where anxiety is more severe. There are other treatments as well, which are gaining, in terms of their evidence base, they're gaining more of that. And so that will probably be updated as time progresses. So launching a bit more into the research part of the talk, anxiety, as we heard, is the most prevalent type of mental disorder. There's a lifetime prevalence of almost 25%. So almost 1 in 4 people will experience an anxiety disorder at some point in their lifetime. So that's not at a point in time or in a particular year, but at some point in their lifetime. Despite this, it's relatively neglected in research, which I guess is always a bit of a, I always get on the soapbox a little bit about that. There is increasing evidence that anxiety may be a risk factor for cognitive decline, and we know that depression has overlap with anxiety, and that is already known to be a risk factor for developing dementia. Being physically active may actually reduce risk of developing anxiety. There are a number of cohort studies showing that now. And we know that non-pharmacological treatments are first line for anxiety, especially with older people, for example, people that I see, because they can have more adverse effects with medication or medication interactions. But we do need more research to guide this, and we'll talk about this. And also, we know that a one-size-fits-all approach is not really effective or really acceptable either. And then interventions that prevent chronic disease, such as dementia, we should be thinking about those really all through life, but particularly it should be thought about in midlife and not just in later life, because midlife seems to be that kind of period where you get a lot of potential to make an impact on health trajectory. So we wrote an editorial a few years ago, just getting on that soapbox about why we're not paying enough attention to anxiety disorders in later life. And you can see in this chart here that we looked at Medline publications as a kind of proxy indicator of how much research was being done, and we looked at aged and depression and aged and anxiety, and you can see there's a big difference between depression in yellow and anxiety in blue. And I want to stress it's not a competition, of course, but it's just an indication of the fact that we've got the highest prevalence condition, not, I guess, being researched all that much in comparison. And if you want to read about what we've said about this, there's a reference there, and will also be in the recording if you don't have time to see where that's come from. So switching over to dementia, I'm talking a bit about anxiety, dementia, and physical activity today. Dementia, we know that it's highly prevalent, and the prevalence is continuing to increase. It is now the highest cause of mortality in Australia and second leading cause of disease burden. The cost is $1.3 trillion globally in 2019. And given this, we feel that dementia risk reduction should be a public health priority, especially in the absence of accessible disease-modifying treatments. The Lancet Commissions on Dementia have shown that, and the most recent of these has shown that around 45% of our risk is potentially modifiable. And this is a very empowering message. I mean, there are a lot of conditions where there is not as much modifiable risk, but almost half of our risk can actually be changed. And that should be an empowering message. And in countries like Australia, it's different internationally depending on issues for those particular populations. But in developed nations, including Australia, the biggest single risk factor is actually physical inactivity. So that gives you a sense of why I'm talking about that a bit more later on. And the population attributable fraction is 8.3%. So that is the statistical way of saying if we were to remove physical inactivity as a risk factor in Australia, so that everyone was meeting physical activity guidelines, then 8.3% of new cases of dementia would then be prevented. However, the results from physical activity trials remain somewhat mixed, and so we need a bit more research. So this is just a really nice graphical way of presenting the risk. So on the left, we have the Lancet Commission, where you see that the risk factors add up to 45% that's potentially modifiable, and then the Australian version of those numbers, and you can see there that physical inactivity at 8.3% is the biggest circle on that pathway. Again, Sorry, I've been doing the soapbox thing a bit too often, haven't I? This is another soapbox thing where a number of us wrote about how we needed to act more on dementia prevention, and we put together some recommendations about what we should be doing, including what I'm going to be talking about in the studies coming up. So in terms of physical activity, we know that it has many benefits for physical, mental, and cognitive health. But despite this, most of us in Australia are not meeting the guidelines. So that's a bit of an issue. Even though we know it's good for us, it's hard for us to do it. There's emerging evidence that exercise interventions reduce anxiety, but that's still sparse, and the evidence gap is even bigger for midlife and later life. And this midlife group have a high risk, or the group of people have a high chronic disease risk and thus have a lot of potential for benefit. So we also know that trials often show that physical activity trials are beneficial short term, like for that year or so, but we don't know how to help people continue in the longer term. We know that interventions need to be tailored to consumers' needs and preferences. We think that technology has potential to help us engage in exercise, and we also need scalable interventions, as many interventions are quite resource intensive, as you'll see with some of the studies where it's required a lot of kind of input, which probably some people do need, but then if we want the whole population to benefit, we also need things that are a bit more scalable and affordable to do for the group of people that can potentially do more online or self-directed interventions. So with the studies that I did, I should note that these studies were part of my PhD, and I've submitted that thesis recently, as Catherine has said. So I'll talk briefly about 3 studies. I'm sorry to rush through 3 studies in a short space of time, but I can answer questions if anything's been too rushed. But the overall aim of the work that I've been doing over the last 7.5 years is to design and assess the feasibility and acceptability of an intervention to reduce dementia risk by increasing physical activity levels and reducing anxiety in midlife and later life adults with clinically significant anxiety. So that's the overarching aim. And there are 3 studies that have contributed to that. So the first question is, we wanted to ask, are exercise interventions actually effective for reducing anxiety in midlife and later life adults with anxiety disorders or subthreshold anxiety disorders? So we did a systematic review. We registered it. We looked at adults aged 40 and over with anxiety or subthreshold anxiety disorders. We looked for randomized controlled trials of exercise interventions where one of the primary outcomes was a change in anxiety. And as you can see here, it was a lot of work. We had to screen 8,432 articles and only ended up with 4, which was kind of disappointing, but also emphasized to us the need for more research in this field. And as you can see from the kind of risk of bias table, which is a Cochrane tool, there was some variability in the kind of methodological quality of the studies as well. So green being where there's a low risk of any bias issues, and yellow being where we just couldn't tell based on what was written, and red being where there's a high risk. So you can see variability there. So we interpret the findings based on that as well. So I won't spend a long time on this, but effectively we found these 4 trials, 132 participants in total. The interventions included a home-based resistance exercise program, supervised group-based aerobic program, a Tai Chi program, and a supervised group-based aerobic and strength combination program. 3 of the trials focused mainly on later life and 1 on midlife. And 3 trials showed an improvement in anxiety, which was statistically significant. 1 trial showed that both of their groups improved, but they couldn't find a difference between their groups. So we concluded, and the publication is there if you're interested in seeing a bit more detail, but we concluded that there was limited support for the potential for exercise interventions to be effective, feasible, and safe for reducing anxiety. So some support, but as you can see, limited numbers of studies. There was a sense that the more tailored interventions to anxiety might increase uptake and decrease dropout. We saw that the one that wasn't quite so significant was more of a sub-study of a larger study where it was an exercise intervention that wasn't specifically for people experiencing anxiety. There are more trials needed, but we also felt that it's probably still worth recommending already that exercise interventions might help because of all the other benefits that exercise has and the fact that it's a relatively safe intervention to be involved in. So the second study wanted to answer the question, what are the perspectives of midlife and later life adults towards physical activity interventions, including the role of barriers and facilitators, such as anxiety and technology. So there's a little bit of a story to this. I'll try and make it as simple as possible. So what we did here was that we asked everyone who was involved in a study called Indigo to come back years after they completed Indigo. So by way of background, the Indigo trial was a randomized controlled trial recruiting people aged 60 and above who were insufficiently physically active and also had some memory concerns. And they had a 6-month home-based physical activity intervention with goal setting and peer mentors compared to having standard education and peer contact. So even the control was a bit of an active control, as you can see there. So the key findings from the Indigo study was that they unfortunately couldn't find a difference between the two groups, but as a combined group, there was a significant increase in physical activity with time. So whatever was happening so either of the approaches was leading to a significant increase in physical activity, which was a very positive result. And that increase was a mean 1,662 steps per day at the 6-month mark, and a moderate and vigorous physical activity increase of about 165 minutes per week. It also had really good adherence. So both approaches were really quite effective, which was quite a positive finding, and also gives a sense of how intensive an intervention needs to be. And perhaps it might also reflect that different people might benefit from different intensity of support. So just nice to actually see what people have said. And Eunice Cooper was one of the participants who's given us permission to say that, as she has co-written an article about her experience of being in this study that was published in the university's Pursuit magazine. And she talked about how she needed to improve her walking strength so she could do a refresher course for basic swimming and also preparing to get a dog. She'd recommend the project to anyone. After the program finished, she joined a walking group for 4 years, went to physiotherapy class. Then COVID came up and she discovered how adaptable she was. She felt, on reflection, it certainly helped her step in the right direction, and also helped with being a real mood changer with fresh energy running through her veins. So really nice description of her experience there. So like Eunice, we asked the other 42 people who've completed the Indigo trial to come back, and on average this was around 2 and a bit years to even 5.5 years after their baseline. So the trial went over quite a period of time, recruited over quite a period of time, which is why there's such a big range in time frame there. And I interviewed all of them during a semi-structured interview. I won't go through all the questions, but essentially we asked them about their experience of Indigo. We asked them about barriers and enablers, and also what they thought about anxiety and technology. So, no, really encouragingly, even though it was years after they participated, we had 2/3 of people come back to be interviewed. Some people had relocated. Unfortunately, some people had passed away. Some people were too busy um, or were unwell and weren't able to come along. We had one other person actually come along, but unfortunately, they had developed dementia and so no longer had capacity to consent, even though they were keen to be part of the interviews. So just a pictorial kind of representation of the 29 participants who came back for an interview, who I spoke to. You can see that the majority were not meeting physical activity guideline levels in terms of the aerobic physical activity guidelines at baseline. All of them pretty much had an increase in activity during the trial at their second visit at the 6-month mark, with many of them or majority meeting guidelines. And then it was about half at the 4th visit, which was the visit that happened with us a few years later. So the headline kind of summary of what we found was that there were some clear themes that helped people with motivation to get involved in physical activity. So that sense of having some structure and accountability, having some awareness of what to do and how it benefits them, and having that tailoring to their preferences helped motivation as well. And a lot of people mentioned that some of the tools like the goal setting was helpful as well. Then the next piece of the puzzle seemed to be having the right situation. So environmental factors, time factors, social aspects, and also the issues of aging and their physical health status at the time seemed to be really important to leading to action on physical activity. I think the longer term maintenance themes were the most interesting because of the fact that there hasn't been much out there in the literature where people have been followed up and asked about things that kind of long after the intervention. So if I was to very kind of briefly cover that, the probably the biggest two themes that came out of helping with longer term maintenance were around that sense of self-efficacy. So feeling like they were able to do it and the perceived benefits. So feeling that they were getting some benefit out of it. The other prominent theme was around the formation of a habit, and there were a number of people who actually spoke about how when they stopped doing it, they actually missed it or even had a bit of withdrawal from it. And so that kind of helped them get back into it again, which was a really positive thing. And for some people, enjoyment was a big theme as well. So finding something that they could enjoy seemed to help them keep going, which that makes intuitive sense, I think. In terms of anxiety and technology, anxiety was a bit all over the place, hence the picture there in the background. It's quite a broad understanding of anxiety, but also quite a lot of variation around level of mental health literacy around this. So that kind of emphasized to us that an important part of an intervention would be providing some information and education around what anxiety is and how it can be helped. We also found out that a lot of people felt that exercise could be helpful to reduce anxiety, and people spoke about it as a kind of process which was quite mindful and a distraction from their worries. And other people also spoke about how they thought it might be a physiological process with that blood supply and oxygen to the brain helping us with our anxiety. In terms of technology, this was a polarizing topic. I think it kind of reinforced some degree of digital divide. There were some people who were quite positive, and there were others who quite disliked technology or had concerns, for example, about safety. People who were positive about technology felt it could help with providing information with health monitoring and also with motivation. And the types of technology they were quite open to trying were around wearables, online platforms, and portable devices. Again, this is published to if anything you're interested in reading a bit more detail about, you can refer to that. And in the time remaining, I'm trying to leave plenty of time for questions. I'll talk about the final study, which was called the EXTRA study, which stands for Exercise Therapy to Reduce Anxiety. So this comes to the question of what is the feasibility and acceptability of an exercise intervention to reduce dementia risk by increasing physical activity levels and reducing anxiety in midlife and later life adults with clinically significant anxiety. So the extra pilot intervention trial is the next thing that I'll speak about, and we have here a protocol that's published, and there is a results paper that's currently under review. So the study here was an 8-week self-directed, thinking about scalability, so self-directed with potential to be automated in future, web-based exercise intervention facilitated by a Fitbit, so taking on board that wearable idea as well as the online platform idea. And there were tailored behavior change strategies which were optional that people could choose to use. So again, thinking about the Indigo results and how it seemed like people could benefit from them, but there were some people who preferred some tools and others who preferred other tools. So we wanted to give people that option. We hoped that it would be feasible and acceptable. That was the kind of primary outcome we were looking for, but we were also looking for some indicators of whether it might be helpful or effective, keeping in mind it's a pre-post study and not there's no control group. So in terms of the methods, in the blue hexagons, we have examples of what the program involved. And in fact, it wasn't a reinvention of the wheel, but we tailored and adapted the resources from a study called Excel, which I will show you the reference for, which was led by Catherine and other colleagues. Catherine as in our chair and host today. We have used resources from that program, which has recently been published and been helpful in being effective in increasing physical activity and helping with mental health outcomes. So that resource was kind of translated into a web-based self-directed resource and put onto the platform. We recruited 21 community dwelling adults aged 40 to 79 who had clinically significant anxiety according to the DASS scale. People had to have capacity to be able to consent and be able to access the platform and safely undertake unsupervised exercise. We also had a lived experience researcher on the team who reviewed all the content and helped to trial to test run all the package, and also met with the web designer and myself on numerous occasions. So just in terms of some of the resources that were being used, we based our work on the National Physical Activity Guidelines, both for the general population, also the ones that we had developed on the screen there for people who have subjective memory complaints or mild cognitive impairment. And that's the team there who developed it. And as you can see there's Catherine and team's article showing the effectiveness of the Excel program from which this is based. And as an example, this is one of the adapted Excel programs, example walking programs that we adapted for the Extra project. And again, we tried to make it very individualized so people could choose and substitute other types of exercise into their programs, and didn't have to follow these programs strictly, but the aim was to meet the 150 minutes a week, or if they're already meeting that, to increase from that. And if they preferred to cycle, or if they preferred to swim, that was absolutely fine. We're very much keeping in mind that people are more likely to continue doing the program after the research ends if they enjoy it. So in terms of what happened in the project, we had 40 people complete screening, and interestingly, 15 people were excluded at that point because they didn't score highly enough on the DASS anxiety scale. So either the scale didn't quite work for our particular cohort in terms of the aging cohort, or our group perhaps were misidentifying symptoms of other types of conditions as anxiety, perhaps stress or depression was being misinterpreted as anxiety. So that is important food for thought for our future research. So 25 people met study inclusion criteria, but 4 for various reasons couldn't commence or didn't actually answer my calls or emails. And the 21 people who commenced actually all completed the intervention. So that was really encouraging. You can see there a range of ages ranging from 40 up to 77, range of educational levels from 8 years up to 27, a range of body mass indexes, 3/4 female compared to male, which is not unusual in these studies, a range of mental health diagnoses, but not surprisingly, anxiety disorders was the most common. We wanted it to be kind of transdiagnostic because anxiety can occur for anyone. So we were inclusive of people with all sorts of diagnoses, unless that particular diagnosis was kind of in an acute phase at that point, and their kind of primary concern. And interestingly, only 6 of our 21 were taking psychotropic medication. So in terms of the evaluation questionnaires, most people enjoyed it, and also on the Likert scale. We also had good results for how helpful people found it, how useful people found it, and whether it changed their anxiety. No one felt worse, but for some people they didn't feel it necessarily changed their anxiety, and for others it improved. So in terms of going on from there, many people the majority of people wanted to continue doing exercise after the project. Some people wanted a mixture of online and in-person. Ours was totally online. And most people found the website and the Fitbit surprisingly easy to use, which was encouraging given the digital divide concerns. In terms of examples of some of the feedback, I don't really have time to go through all of this, but essentially I've just given some examples of what people had said, and also some of the examples which were more constructive criticism as well. So I can come back to that if needed, but I'm just wary of the time. In terms of the actual statistical results, keeping in mind there's no control group, we did find that from baseline to week 8, there was a significant increase in steps per day, almost 1,400 steps more, and also the fairly and very active physical activity time per week, so an increase of 81 minutes per week. Interestingly, this wasn't shown on the self-report scale, so that was interesting that the objective measure was more prominent on that. We found that stress and depression had statistically significant reductions. Anxiety did have reduction, but only approached the significance, but didn't make it there. So that was an interesting observation. And one of our suspicions there is that between screening and baseline, a fair percentage, so actually 8 people actually had a reduction of anxiety just by enrolling in the study and had no longer been above 7 at the baseline point. And that was only in a matter of a week or a few weeks period. So we thought that could be a kind of placebo effect of enrollment in a study, hence the importance of a control group, but can also be part of that sense of empowerment or self-efficacy from actually, or achievement, sorry, from actually enrolling in something and taking that first step, which is quite difficult when living with anxiety to actually make a change, and that can help with anxiety in itself. When we did an exploratory analysis, just looking at the subgroup of people who were still over that DAS score of 7 with anxiety at baseline, the reduction in anxiety then reached statistical significance. And that kind of makes sense because I guess it's hard to show a change if you start off with a low level. So some additional results you can see here, the change from screening to week 8 is actually a lot more prominent than baseline to week 8. So there seems to be a placebo effect or some kind of sense of mastery or achievement effect from enrolling in the trial. So we can find out more about this when we do a randomized controlled trial, because there will be a control group. So overall, it's the first feasible and acceptable online self-directed exercise intervention facilitated by a wearable that we could find in the literature. It's for midlife and later life adults with clinically significant transdiagnostic anxiety in a real-world setting. Positive signs of efficacy, noting small sample size and no control group, with some effect sizes and potential to be scalable and automated. And there are some improvements we can make based on the qualitative feedback as well. So strengths, the 3 studies have used a mixed methods approach. There's a diverse and complementary expertise in the team who I cannot thank more because they've been so instrumental to helping me do all this research. So I appreciate the team greatly. We've engaged with consumers, we've addressed evidence gaps, and we've hopefully engaged with real world participants. We've got some limitations as mentioned. And the next step is to hopefully be able to obtain some funding to do a randomized controlled trial to actually show efficacy now that we've shown feasibility and acceptability. And if we can do this, and it is effective, then it has the potential to impact 3 significant health challenges on a large scale to reduce their resultant morbidity, mortality, and cost. And the 3 health challenges are all high prevalence, including physical inactivity, anxiety, and dementia, and looking at reducing risk of dementia. So it wouldn't be a research talk without a little bit of advertising, so I'll quickly do that. So I work on the Healthy Aging Service at St Vincent's Hospital. We're a multidisciplinary service, including a therapy dog that provides support to people in the Eastern Melbourne Primary Health Network catchment that are aged over 65 and need more than primary care support, but don't necessarily meet the referral criteria for the tertiary specialist mental health services. We have developed some resources that you're welcome to use and download. So these are resources, help sheets developed by our team for residents in aged care facilities and their carers, and also some training videos for aged care workers, which are also free to access. So you're welcome to use these as well. And the next one is a research trial that we're currently recruiting for in partnership with the University of New South Wales, who are the lead institution. It's called Cog Coach Health, and it's a 12-month randomized controlled trial online intervention focusing on dementia risk reduction, which also includes some virtual consultations with an exercise specialist, psychologist, and dietitian, focusing on lifestyle risk reduction for dementia, and available for anyone in Australia because it's being done online. So that's something that is very much important to us. And then my acknowledgements here are to all of the research participants, all of my PhD supervisors and advisory committee, and the research team, which is listed there and includes Catherine, who's chairing and hosting, and also the funding that has been received for these studies. And that leads us to some time for questions. Thank you for coming on this whirlwind tour of what's been happening. I'll stop sharing so that we can see each other.
Thank you, Terry. Fantastic. Lovely to see the progression, I think, of the work, and to take us through a bit of a whistle-stop tour of what we know about anxiety in older adults. Now we can open up for questions now. Just a reminder, we don't have the chat open. So if you'd like to ask a question online, there's the Q&A little button at the top. It looks like a couple of little speech bubbles. Just press on there and type your question in. Otherwise, feel free to press that raise your hand icon, and I'll be able to organise for you to be unmuted and your video on. Just a reminder, though, that you'll be included in the video that goes online after today. So we'll just give everyone a little bit of a moment to see if they've got any questions, and we've got some popping up already. Okay, let me just start with this one here from Cobby. I hope I'm pronouncing your name correctly. And it just says here, thanks, Terry, some great info, and I agree. Given there are different types of anxiety disorders, which anxiety type would benefit most from increasing the exercise participation from your point of view? I think that's a great question.
Yeah, thank you, Cobby. That's a really good question. So, I mean, I guess my thought there was that any type of anxiety would benefit, and that's the approach that we took in our trial, in that we didn't really want to, we didn't even specify in our trial they had to have a specific anxiety disorder. It was only clinically significant anxiety, and the sense that I got there was that people were benefiting from it, but the proviso being it's a pre-post study, as has been mentioned. But if I was to be pushed to pick a type, I'm just trying to think. I mean, my kind of, I've got no kind of science to back this up. This is a gut feeling more than anything else. But my guess is that people who particularly experience a lot of the physical symptoms of anxiety, so that very prominent fight-flight response, may benefit more, but that's just a guess. And I think partly because it's kind of changing the individual's sense of physical symptoms as well, and in their relationship with that. I mean, that's been a bit of a challenge, though. There is a phenomenon called exercise anxiety, which is recognized, and it's where somebody who does have anxiety and prominent physical symptoms can actually misinterpret the physical effects of doing exercise, like the sweating and the shortness of breath and the muscle sensations and the potentially some lightheadedness and so on. That can be misinterpreted as anxiety and can be a barrier to actually engaging in exercise. So that was an important part of the education component and the information component of the intervention we were running, and may be part of the reason why that tailoring of the information could lead to interventions that are more helpful.
Great, thank you. Daniel writes, fab presentation and body of work, Terry, thanks. Thinking of the language you used across this, two things came to his mind. One was exercise versus physical activity. So does the dose matter? And two, enjoyment seemed to be a key factor that you kept coming back to. Is this more important than other variables such as dose or type?
Yeah, it's a really good question, and I think
Fabulous question.
yeah, it's a really, really good question. Thank you, Dan. I think it's something particular, and it's something I get pulled up a bit on too. I think particularly by the exercise specialists on the team, and that's the real value of the exercise. Sorry, of the multidisciplinary team environment, because the exercise and physical activity have very clear definitions, and exercise being a subset of physical activity. Although I have tended to use the terms fairly interchangeably. I guess the extra study did look at exercise specifically, and that it was that kind of deliberate and repetitive and structured physical activity with that view to build physical fitness. And that's why they had those example programs that we wanted them to look at and adapt to their situation and their preferences and their particular needs. And at the same time, we were also using the Fitbit. We were kind of measuring more, I guess, physical activity levels as opposed to using the self-report scale, which was more targeted towards the different types of physical activity they were doing and how much and how often, for example, physical activity for transport versus occupation versus leisure, and not including incidental activity. So in terms of your other question, so your question there, does the dose matter? Most of the research is really that I've seen has focused on meeting those physical activity guidelines, and we tried to do that with the aerobic guidelines, which is usually that 150 minutes per week of moderate to vigorous, and that seems to be where the research lands on in terms of what is helpful. Although with anxiety, I guess it's not quite as clear, but I know that in the depression field, there's been a lot more research, and that's a lot clearer. So that's probably what I'd say about dose. And in terms of enjoyment, yeah, it's hard to tease out how much of each of those things is important, but I think you're certainly right. I think enjoyment is important. We couldn't quantify, how much impact that had, but we kind of focused on that as being important for someone continuing it, given what we found in Indigo. But I guess the other part of it is that there are all those kind of mental health benefits of being able to enjoy something and kind of that behavioral activation of getting back into things as well. So really good points. I don't have a quantifiable answer, but I think they're really important.
They are, and we've got a few questions here. We may not get through them all, so I'll ask those that have sort of been upvoted first. Scott was curious about the consideration of strength-based training or other forms of exercise training, plus or minus the walking intervention. I wondered if you wanted to speak to that, Terry.
Yeah, absolutely. So I think in anxiety, there's still not a whole lot of research in the space. There has been a bit more since we did the systematic review, but there are studies that are aerobic based as well as strength based. We didn't do that in this particular study because we were concerned about how we could do this safely, having not met the person, and potentially comorbidities and age and so on. But and not and thinking about this kind of scalable intervention. But in the study, in the Excel study, which we spoke quite a bit about, there was a focus on the strength-based resistance training as well, which was found to be beneficial. So hopefully in the next trial, we can try and work out how we can do this accessibly and safely in a scalable way. So
And I
thank you
think
for that.
that really speaks to a question here from David around, the challenges of, real world barriers. So we do have a question here from Jane that I think is really interesting, not one I've thought of, and I wish I had thought of this myself. She wants to know, were any participants from the same household? From memory, there seems little research, and I would agree on that sort of
Mm,
peer motivating peer within a household. knowledge from your mindset and data set, Terry?
That's such a great question, Jane. So in our study, no, there wasn't anyone who came from the same household, but I think that's where the Indigo study kind of focused a lot on involving, having peers that kind of act as mentors as an active intervention to help with things like motivation, and that structure and accountability theme came up quite a bit. I think that's a really good suggestion, and something that we did encourage people to consider doing their exercise with another person, if that was an option for them to help with motivation, and also those social benefits, which are really helpful for our mind as well. So I guess to explain why we did what we did in extra, we were particularly cognizant of other studies having been quite resource intensive, with a lot of intervention from the research team, meaning that it couldn't necessarily be scalable. So Excel was a bit more resource intensive, with researchers acting as coaches and helping people with their programs and so on regularly. And for a group of the population, that would be needed. Otherwise, they wouldn't be able to engage in this sort of program. And then this particular take on the program on the exercise idea was to try to have a scalable thing that virtually anyone could log on to and do without having to have lots and lots of resources behind it. And again, being aware that that would only kind of work for, again, a proportion of the population who would benefit from that self kind of motivation process. And also those who had the preference. I had a number of participants actually say to me, I like it that, I don't have to meet with somebody regularly because, that makes me anxious, and I prefer that we just meet at the start and the end, and that I have the resources that I can use through the program.
Beautiful. Thanks, Terry. I'm conscious we've just run over time, so I'll bring the meeting to a close. Please join us next month in May when Ben Kirk will speak on sarcopenia. That will be another great talk. And please help me in thanking Terence Chong for the fantastic presentation. Thanks, Terry, and thanks all. We'll see you next month.
Thank you, everyone, for your attention.
Wonderful. Well done. That was very interesting. Well done. Just give me one second.
Yes, that's right.
Well, this is always the awkward moment where we'll kind of kick people out of the meeting here at the end. But that was fascinating. I found that was very
good.
Very interesting. You covered a lot of ground, of course, and the time that you had.
Really fabulous. Thank you.
It was hard to know how much to cover, but
always hard, as you said at the start. Always very hard to know pacing, etc. But it was beautiful, great, and great questions. I'm sorry we couldn't get to all of them fully.
Yeah, well, that was probably me talking for too long, but
no, you did it absolutely fabulous job. I think it was a great seminar. So thank you. I'm going to have to be really rude. I've got a 1 o'clock that I'm a couple of minutes late for. Do you mind if I jump off?
No, of course, absolutely. Thank you so much here. So just so you both know, thank you. I'll close this out here. We'll upload the recording to our website, and I'll send through the link to you, Terry, when it's available. If you care to review your own presentation, or you could perhaps forward it on to your own networks there too, if you'd like to pass along the bits. And I'll be in touch later, Catherine. I think we've got you speaking later on in the program for 2026 here. So excellent.
Thanks, Dave. Appreciate it. Thanks, Terry.
Wonderful.
See you later.
Brilliant
Thanks
done.
very
Well done,
much.
Terry. Thanks so much. Have a great day, guys.
You too.
See you later.
Bye.